Welcome everyone to the Ontario Webinar 2024-25 webinar series. Today, Dr. Jaris Swidrovich will be presenting on decolonizing evidence-based medicine. At the end of the webinar, a survey will pop up, and if you could take a few moments to fill it out, that would be great. It'll also be sent to tomorrow, the following day. If you don't get a chance to do it today, but thank you. And now we welcome Dr. Jaris Swidrovich. Miigwech.
Thank you so much, Miigwech Clay, and to the Ontario NEIHR for making this space available to folks. Often this type of education is inaccessible to the masses, both Indigenous peoples and non-Indigenous peoples. So I'm thankful that we have an avenue to share this kind of work. I'm going to go ahead and share my slides right here now. So my name is Jaris. I often say just like Paris, but with a J. And I am both Saulteaux and Ukrainian from Yellow Quill First Nation in Saskatchewan. Yellow Quill is on Treaty 4 territory and the Métis homelands. I've spent most of my life in Saskatoon, Saskatchewan, or Treaty 6 and the Métis homelands, but now live in and am joining you from Treaty 13 area, or Tekaronto, which is a Mohawk word for Toronto, which means the land where there are trees standing in the water. I'm a pharmacist. I'm an assistant professor in the teaching stream at the Leslie Dan Faculty of Pharmacy at the University of Toronto, and also our faculty's Indigenous Engagement Lead. And somewhat recently, I'm the founder and chair of the Indigenous Pharmacy Professionals of Canada, or IPPC, and I encourage you to check us out. You'll certainly find some links to those other those other entities in my various social media handles, which I've shared at the bottom of this particular screen. In my world as a pharmacist, a healthcare practitioner in general, as an academic, as a health provider, a teacher, the area of evidence-based medicine is around me in every way, shape, and form. And we often refer to evidence-based medicine as exactly just that. My long story short, if you learn nothing else or take away nothing else from this webinar, is basically just to add the word Western before that as the take-home message. So Western evidence-based medicine is usually what we're referring to, but there are certainly evidence from all knowledge systems across this whole world, including Turtle Island. And the focus that I will share is the Indigenous versus non-Indigenous as large entities when it comes to evidence-based medicine. I shared where I am here today, and I encourage folks always to think about the land from where you are joining and what that means to you. I also usually ask folks to consider that if you're in a place or space that is unceded, for example, Ottawa, our nation's capital, unceded is really just a polite word for stolen, right? So unceded means there was never a transfer of title, there was never a purchase, there was never a movement of ownership or agreement. It was just simply occupied and remains occupied without ever any official transfer. So even our nation's capital is on stolen land in what we now call Canada. What I'm going to share with you today, I hope that by the end of this presentation, folks will be able to summarize evidence-based medicine through decolonial and Indigenous lenses, name and critically evaluate evidence-based medicine regarding the knowledge systems that inform it, and then finally suggest how to bring Western knowledge systems and Indigenous knowledge systems together in whatever your line of work might be, even if that's simply being a member of society and doing some micro reconciliation if I can, whether it's at a dinner table, a coffee shop conversation, a hallway conversation, promoting and sharing that there are more than one knowledge system that exists in this country. A disclosure, though, as I get started, I want to share that the content in this lecture is not meant to discredit or delegitimize what is taught, learned, and practiced in the evidence-based professions. The content is more so meant to promote introspection and metacognition, metacognition being thinking about your own thinking regarding what we teach, learn, and practice in health professions. And I'll repeat this now and frequently throughout the conversation in that I too am a Western trained health professional who practices within the structures of Western medicine, and I will continue to do so. However, the difference is just simply that, naming the knowledge system behind the practice or naming the knowledge system from where you are standing, your vantage point, in other words. I like to bring in my own relatives into this space when I draw on such ancestral knowledge and pay respects to those like my family and many others who have paved this path for me to exist, just simply exist in places and spaces like the ones I'm in. We still have a lot of work to do. I know that in my own discipline of pharmacy, there still remains only one Indigenous pharmacist faculty member in North America. So we've got a long way to go in terms of learning about various knowledge systems and making space for Indigenous people specifically in this discipline. Every person has their own unique outlook on the world, oftentimes referred to as a worldview, sometimes even referred to as a paradigm, the way in which you see the world, how you perceive the world, the theory of existence, essentially. Your worldview is informed by generations before you, your family, your friends, your political views, your abilities, disabilities, ethnicity, height, even your tone of voice, your gender, your sexual orientation, the year or generation or city or country you were born in, the professions of your parents, caregivers, the teachers you've had, and all of the social circles that have existed around you. For me specifically, I do like to acknowledge and make it very clear that I know I'm a white presenting person, period. And that alone has afforded me many privileges and power. And for someone like myself who exhibits two identities in many senses of the word, I do identify as two-spirit. I am both status First Nation and Ukrainian or white. I'm a middle child, so in the middle of two worlds in that sense. And then also navigating knowledge systems in my chosen discipline of pharmacy, like many other evidence-based professions, in that I navigate and try to find a medium between Western and Indigenous knowledge systems. Indigenous learning outcomes are critical in health professions education and continuing professional development. However, few, if any, standards are mandatory from national or local perspectives with respect to Indigenous content. Oftentimes in medical, nursing, pharmacy, and other health-related disciplines in the accreditation standards, in the learning outcomes, you might find cultural humility, cultural safety. But my argument over and over the past number of years is that you can still absolutely meet those requirements of teaching about, learning about, being competent in cultural safety without ever even mentioning Indigenous peoples, for example. Cultural safety as a term, as a concept, is not specific to culture, nor is it specific to Indigenous peoples. Cultural safety was coined down under in the Australia, New Zealand part of our world. And what it really refers to primarily is power and power dynamics and hierarchy. And so practicing culturally safe care truly means breaking down hierarchy, breaking down power imbalance, which has a large connection to the way Indigenous peoples access care or prefer to access care, for example, as well as very many other communities, subsets of our populations, religious groups, cultural groups, ethnic groups, etc. Many will agree that decolonization is required before indigenization takes place, and so I'm presenting this in the context of evidence-based medicine. But what is decolonization in the academy or in this intellectual space of academia? Some folks have many definitions. The one that I'm working from is that decolonization is a multilateral process of understanding and unpacking central assumptions of domination, patriarchy, racism, and ethnocentrism that continue to glue the academy's privileges in place. One very specific example of how those systems continue to operate is I know that various universities across the country and world are working on things like Indigenous standards for promotion and tenure in a professorial stream. And I've certainly heard commentary from folks of Why are we doing this? Show me the evidence for that. We've had these systems in place since the beginning of academia. Why does it need to be changed, right? So you see here domination, patriarchy, racism, ethnocentrism in those statements alone. And that continues to hold the academy's privileges in place, even when the academy is made up of individuals. But there's this collective school of thought that these central assumptions must remain true for a system like academia and like health professions in general. Indigenization can be referred to as the transformation of the existing academy or health science professions by including Indigenous voices, knowledges, critiques, scholars, students, and materials, even including physical spaces and epistemic spaces, which is like the systems of thought and knowledge systems that facilitate many Indigenous knowledges. So you'll see I've pluraled, bolded, and underlined the S on Indigenous knowledges. This is to emphasize that Indigenous in the Canadian context refers to First Nations, Métis, and Inuit. And even within each of those groups, we have so many different kinds of folks. So I'm Soto, there's also Cree, Anishinaabe, Ojibwe, Dakota, Lakota, Nakota, very many different denominations of people within First Nations, even Métis and Inuit, as well as folks who exhibit multiple of those identities. Many people close to me are Cree and Métis, for example, and each of those identities may have its own set of teachings, systems of beliefs, knowledge systems, etc. So to emphasize that we are not a monolithic group of people as Indigenous folks in Canada, that's why knowledge is plural, because there isn't just Indigenous knowledge singular. Indigenous and non-Indigenous students in academia and in practice are indirectly, and I would argue that very, very directly, sometimes taught to devalue non-Western medical approaches and medicines when the Western knowledge system that informs such approaches is not named. So the position that I'm taking is that not naming Western knowledge as the source privileges Western knowledge over all other knowledge systems. To be very clear with an example, when it comes time for me to teach something like schizophrenia disorder in pharmacy, I will talk about, or the way that I should talk about it is, here we are going to learn about the Western definition of schizophrenia. We'll talk about Western diagnostic procedures for schizophrenia disorder. We'll look at evidence-based medicine, Western evidence-based medicine from Western knowledge thinking scholars, published through Western peer-reviewed journals, disseminated in Western modalities, and shared in a Western health profession like this one of pharmacy. You can see that if I added that word Western to every step of the process, you'll see that this is very singular, right? This is one perspective. It is not the perspective. And if we don't name Western and we just say, this is how you do XYZ, it seems like that's the truth. And everything else is an other. In fact, we label everything else as an other. Often we say complementary alternative medicine as something different. So anything that's not Western is something different. I would argue, though, in the context of what we now call Canada, the very first policies, practices, medicines were and are Indigenous. So I would say that any other knowledge system in this land, any practice, any medicines being used, medications, prescriptions, those are kind of complementary alternative to the original thoughts and practices and medicines of this land. Indigenous knowledges are often completely dismissed as ignorance, like not knowing. You just simply don't know about all of the Western evidence-based medicine that exists. Or sometimes Indigenous knowledges are valued, but often that value comes from a place of, oh, that's so cool. It's like I'm accessing some ancestral knowledge of the way things used to be way long ago. And for some reason, there's this conception that Indigenous knowledges cannot evolve and continue in the present like other knowledge systems. So when folks talk about, well, that's not what Indigenous peoples did. Yeah, okay, well, maybe 200 years ago or 17,000 years ago, but we're allowed to evolve with time and space as anybody else is. So Indigenous knowledges aren't just something from the past that we've continued to move forward. Our knowledge systems also advance and move with time. Post-secondary students are generally socialized to develop similar ideologies regarding Indigenous knowledges. So I ask folks to think about what and who informs what is taught in post-secondary education. There's no doubt that Western knowledge is privileged in academia and in the Western health professions, and this is what I want to unpack and think some more about as it relates to evidence-based medicine and evidence-based practice. So let's talk about evidence, or EBM, you might catch me saying here or there. To emphasize my point, I'm going to share some direct quotations of things that have been said to me over the years. This one was actually said to me during a job interview. This person said, Jaris, if you really want to make a difference, forget about Indigenous. Go buy a statistics textbook, read it, learn it, use it. That's where the big money is, and that's where you'll make a difference. You can totally appreciate the knowledge system or systems from where that person was standing. And it was perceived by that person that bringing Indigenous ways of knowing, thinking, being, and doing practices, medicines, just simply doesn't have a place in pharmacy, and that it won't actually make a difference. Someone else said, if you can't access a sweat lodge, Jaris, you can go sit in the sauna at the gym. And that was incredibly offensive and remains incredibly offensive. But it was interesting that something like that was said and perceived to be okay by the other folks in the room at the time. To flip things around a bit, can you imagine if I said to a Catholic person, if you can't go to church or midnight mass, you can certainly just go read the Bible in the aisle at Walmart. That's offensive. That's totally offensive. That is not a place of worship. That is not the best place to practice ceremony in a Catholic system. And I would have been shut down for saying such a thing, but for some reason, the comments like this were able to fly in academia. Finally, someone else said, so you think you've been here since the dinosaurs, Jaris? Or do you think God just went poof and there you are? So yet again, not appreciating or respecting Indigenous knowledge systems, and even non-Indigenous knowledge systems. This has absolutely been proven time and time again that we were the first peoples of this land, but non-Indigenous scholars who I've worked with in my own discipline feel completely otherwise. So you can imagine that in a place and space like pharmacy, as an example, where it's only me as the Indigenous academic in this space in Canada, when this type of content is being taught in programs across the country and in other programs, if it's not coming from a decolonized and Indigenous perspective, a lot of danger and harm could come from this, given what you see on the screen. In the Canadian healthcare and education systems and in the scientific community, Western knowledge is absolutely treated as the most legitimate form of knowledge. I think that the drastic privileging of Western knowledge is problematic in the healthcare context, where epistemic racism, which is like the racism of knowledge systems, and systemic racism, which is when systems treat people differently based on their ethnicity or the social construct of race. When those work together to delegitimize Indigenous research and Indigenous evidence, which therefore impacts resource allocation and access to culturally appropriate care. That part I'll expand on in the next little bit here. First, though, hey, you're all going to get a little mini lecture on statins here. And for the non-pharmacists or folks in the virtual room who do not know what statins are, they are medications used for high cholesterol, and not just simply to bring your cholesterol numbers down, but with the hopes that by doing that, you'll prevent something like a heart attack or a stroke or needing a stent put in your heart, for example. Let's zone in though on what's called the number needed to treat for statins for various patient groups, which I'll share on the next slide here. So this comes from something called the RX files. It's a wonderful Western resource, which I use all the time and recommend to people in my discipline and in other Western health profession disciplines as well. The RX files, like many other folks, love them so much. However, they do market themselves as an unbiased or, non-biased evidence-based medicine resource. But you'll see shortly why I think it's incredible bias. So what you see on the screen here, the purple numbers circled, these are the numbers needed to treat for people who have already had a heart attack or stroke, or they've already had an event that required them to have a stent put into their heart. So people who have already had an event happen to their heart, they are at the highest risk of it happening again versus someone who has never experienced the same thing. The numbers on the screen there, you'll see this is how many people needed to be treated with the daily statin for 5 years to prevent one event. And by event, I mean a heart attack. It's listed there, generally cardiac death or a non-fatal heart attack or non-fatal revascularization, which means a stent being put into your heart. And then the numbers on the bottom represent people who have never had an event like one of those, and those are the numbers needed to treat. And I'll just explain that a little bit more deeply here. So for the highest risk group, those purple numbers, people who have type 2 diabetes, established cardiovascular disease. So this is called secondary prevention. We're preventing a second event versus preventing a first event. And on average, this patient population in the clinical trials were male, 58 years old, and they had an LDL of 4.9. LDL is our bad cholesterol, and in general, we like to keep that number under 2, or even bring down people's LDL number by 50% or more when we have brought them into healthcare. For this highest risk group, one cardiovascular event is prevented for every 10 patients treated with a daily statin for 5 years. This is among some of the best evidence we have in these Western disciplines. Statins are such a glorious, wonderful addition to our Western health system and medications that we use. For a lower risk group, so this would be defined as people who have not had an event already, so this is primary prevention. This would be people with hypertension, for example, high blood pressure. They might have 3 other additional risk factors. Those could be things like smoking, high alcohol intake, etc. And then these folks would have an LDL or a bad cholesterol of 3.4 on average. So for this type of group of people, one cardiovascular event is prevented for every 60 patients treated with the daily statin for 5 years. What we teach and learn in disciplines like pharmacy, and what I still teach in my discipline, is that a good number needed to treat is like 50 or less. So if you can treat 50 or fewer people for a period of X number of months or years to achieve one desired outcome, that's a good number. That's a good number for that particular intervention, especially if that particular intervention is not also met with a number of side effects. So if people might experience little to no side effects from that medication, that's great. That if you give it to 60 people for 5 years, you've prevented one heart attack or one death related to a cardiac event. That's still a really nice outcome, an endpoint to have. But let's be extra critical and turn this lens around for a moment. So what's inspired this type of representation that I'm about to show you is reflecting on previous experiences of working with students and practitioners in an interprofessional clinic setting called SWITCH, or the Student Wellness Initiative Toward Community Health in Saskatoon. Long story short, that was a wonderfully interprofessional clinic. We had everything from medical physician to Reiki practitioner, acupuncturist, massage therapists, registered dietitian, pharmacist, you name it, the list goes on. But it seemed to be most often medical students and pharmacy students really quizzing the chiropractor and the Reiki practitioner and the acupuncturist about, I've heard this and that, or I've heard XYZ about your discipline. I also have heard that, in order to continue experience the benefit of chiropractics or acupuncture, that you need to keep going all the time. And I wondered, why haven't you applied that same lens, that same critical lens to your own discipline? Because if you did that to your own discipline, you would know that to experience the benefit of almost all of our medications, you have to take it every day for your life, perhaps, right? So what if you need to go to the chiropractor a few times a month? To me, that's far fewer instances than what's required for our medications that we're promoting all the time. So for that highest risk group that I shared earlier, what this actually means through a different lens is that 90% of patients, or 9 out of 10 patients like this, who are treated with a daily statin for 5 years, will not achieve the desired outcome, right? And it was never explained to me in that way. I don't know that many of us Western practitioner folks apply this critical lens to what we do, but we seem to apply it to other knowledge systems like, okay, so you practice ceremony X for disease state Y in your Cree community, but does that really work for everyone, or what's the evidence for that? Then I bring people right back to exactly this. One of our best medication treatments for people with the highest risk of cardiovascular disease, 9 out of 10 of them aren't going to experience the result that we want. Some folks, perhaps even on this call, will argue, okay, Jaris, that's a little extreme because their cholesterol's still going to go down, etc. But that's not our goal. I don't care that your cholesterol number is suddenly lower. I want your cholesterol number lower to prevent a heart attack or stroke. Just simply existing with a higher cholesterol number is arguably fine, right? But what it might lead to eventually is the biggest concern. For the lowest risk group of people, what this actually means is that 98% of patients like this treated with the daily statin for a period of 5 years will not achieve the desired outcome. I share with folks, you know what? We love statins. I remember thinking and learning in pharmacy school, like, oh my gosh, this is a miracle. Like, statins should literally be put in the water. Everyone drinking tap water should get a little bit of statin because, my goodness, what a wonderful creation. And they are. When I'm putting only my Western pharmacy lens on, I still recommend it all the time. And even high dose right after a heart attack, for example, I still practice, teach, and learn that system. Statins have made the list of most commonly dispensed prescription medications for decades, but I would argue that statins do nothing for more people than they do something for. Of course, I understand that that something is a very serious endpoint, like death or a heart attack, and that's a really great benefit for arguably a low risk. People might not experience any side effects. They might experience something like muscle ache or weakness, and if they do, that usually goes away within days or a few weeks. So it's maybe not the biggest investment for such a wonderful result. I get that. Keep in mind, though, that we publicly fund statins for each of these situations. No questions are asked. When a prescription for a statin reaches the pharmacy, it gets sent to whatever provincial drug plan or private drug plan is there for the person, and it's covered. No other questions are asked, despite even in the highest risk scenario, 90% of people won't experience the endpoint that we want them to experience. So how does this compare to our use or our non-use and discussion and evaluation of non-Western medicines and approaches to health and wellness? When we have discussions about complementary alternative medicine, we criticize and examine it with really careful scrutiny. We want to know how that discipline started, how it evolved, what is taught in that discipline, what isn't taught. Is it 4 years like my degree, or did you just do it in 10 months, right? What evidence informs that discipline's work? What's going on in your classrooms? Why don't we do that to ourselves, though, in the Western professions regarding our Western medicines and Western practices? So I ask these questions of myself and other folks who practice similar knowledges as my own. So who invented statistics as we know it in medical literature? I bet that probably almost everybody doesn't know. But we use it. Whatever they invented, we use it, and we use it religiously and systematically all the time. Who invented the p-value? For the folks who work with stats on this call, you'll know that a p-value of Less than 0.05 is what we consider to be significant. But with just the smallest change in number, coming up with a statistical number of 0.053, we'd consider that, oh, you know what, we can't draw any conclusions from that. That's hypothesis generating based on some rather arbitrary value that is from a system of what someone made up, right? So it's not like stats were just a natural phenomenon given to us on this earth. It was a system developed by someone and a group of people and has evolved over time. Yet again, I use it, I teach it, I believe in it in the Western sense. But keep in mind that it's not perfect. How do we know we are right about something in the Western disciplines? What is the emphasis on reproducibility in determining what is right? I understand that the ways in which we teach, learn, and practice our health professions are precisely what makes them what they are. I'm not suggesting we stop these practices at all. Please continue on, as I will in my Western pharmacy hat. I am suggesting, though, that we name those systems for what they are, adding that word, Western knowledge, Western practices, and Western approaches. Here's some questions to think about in your own educational or just simply personal or professional journey. Who was teaching you from kindergarten through to your highest degree and even post-professional education? Who wrote the textbooks that are referred to and that we found our lectures and curricula on? Who were the leaders of the programs in universities? What knowledge systems are consulted for teaching and learning in your health profession? What knowledge systems are turned to in the practice of your discipline? Think about how many Indigenous folks might be in there, right? After answering all of these questions, I don't know that I've had a single Black person in any one of these spots. And I have had almost no Indigenous folks in any one of these spots until my PhD in education. So it took me that long, and after that many years, and that much money and privilege and power to be able to access something else. Think about how often do I name the knowledge system from what I am learning, teaching, and or practicing? How often do I acknowledge the worldview from which I'm approaching my learning, teaching, and or practice? There certainly has been increased recognition of the importance of Indigenous knowledges to the health and wellness of Indigenous peoples. And as a result, there certainly has been increased efforts to integrate Indigenous and Western knowledges together in healthcare practice and policy, for which I'm very thankful and grateful for. I will share a few things about Indigenous knowledges, though. Indigenous knowledges are unique to each community and rooted in place. They've developed over a long period of time, like any other knowledge system, however, also within a specific and localized context through lived experiences, observations, holistic investigative, and even problem-solving processes. So if you picture yourself as being the very first human on Earth today, let's say that no industrialization has existed, there are no other humans, you're the first and only one. How are you going to learn anything, right? There's no teachers, there's no textbooks, there's no schools. What is available to you to learn from? Well, Earth, the plants, the animals, the land. So we argue that all knowledge can be traced back to land and place and even animals. That's also why we have clan systems. I'm both part of the Bear Clan and Otter Clan. Many of my teachings and my worldview can be traced right back to those animals. The otter specifically resonates very well with me, as otters can exist in two worlds, in water and on land. And that's been a very frequent theme for me too, existing in like the white or non-Indigenous space, but then also in the Indigenous space, existing in the straight hetero cis space, but then also in the opposite space. Being a middle child, walking these two worlds all of the time has been a frequent theme for me. So I continue to look to the otter for how the otter successfully moves through life, and that's great advice for me. Western knowledge is built on the concept of positivism. And positivism is a theory, a concept that essentially means there's a single truth to be discovered about anything. Evidence gathered by any other means would be viewed as inconclusive or ideological. So in my discipline of Western pharmacy practice, we will do placebo-controlled, randomized controlled trials, which we consider to be the gold standard. But if we just simply observe people in their daily lives, aka an observational trial, it's inconclusive, it's ideological. Um, and when we do multiple studies, let's just say I'm making this up right now, totally false information. Let's say I just invented metformin, a really wonderful drug for type 2 diabetes. Let's say I conducted 10 randomized controlled trials with slight variations in the patient population, inclusion, exclusion criteria in each trial. Let's say 7 of them showed, oh my goodness, this drug's amazing. Let's say 2 of them showed, ooh, maybe not. It's kind of arguable. And then let's say 1 of those 10 was like, no, this is not a good drug. More people experienced harm than benefit. What we usually do in this Western evidence-based medicine system is, well, that can't be right. So let's combine it all, right? Let's combine it all in a meta-analysis. Let's create a forest plot. I want to see, does it work or doesn't it? There's a single truth to be had, and we cannot simply live with the fact that 7 studies might be true, those other 2 studies might be true, and that final one also might be true for the given context, geographic location, etc., recruitment criteria. There has to be one answer, right? Colonial policies and practices, such as residential schools, sought to eradicate Indigenous knowledges. In fact, our languages, our practices, our ceremonies, everything, not just were they not welcomed or allowed, but you could go to prison or be harmed for practicing or using any of these Indigenous knowledges. This concept is called cognitive imperialism, so almost like a taking over of the mind and the ways of thinking for someone. I argue that in our Western health professions that we cause cognitive imperialism to folks coming through. So I hear in my own discipline, let's recruit and retain and graduate Indigenous pharmacy folks. Then they can go on to either physically go back to their communities or wherever they might practice. Then they can provide best possible care to Indigenous peoples. But during their 4 years or however many years we have them in these systems, I argue that we cognitively imperialize them and we either systematically, indirectly, or directly devalue Indigenous knowledges, practices, medicines, etc. So that by the point that they graduate from our program, we've actually robbed them of the ability to work effectively in their own communities because we don't share other knowledge systems, or at least not in a good, dedicated way besides Western. Indigenous knowledges are largely absent from Canadian research, policy, and practice because generally the methodologies don't fit within that positivist paradigm. Further, when it comes to clinical practice, where do we turn to inform clinical practice guidelines? Or if any one of you was assigned to create the 2024 Canadian Clinical Practice Guidelines on disease state X, how would you come up with that? Well, what we do in Western evidence-based professions is we go to the literature. And the only things that exist in the literature are funded clinical trials, researchers of high power influence who were able to get money to conduct the research, to publish it in peer-reviewed trials, and for it to exist among the literature in that way. That's all we really take. We do also take other evidence, sometimes just the consensus opinion. In fact, we call that grade D level of evidence. We have grade A, grade B, grade C, and grade D evidence. Grade D evidence comes from the expert consensus opinion of folks in that field. And there's no specific number. It could be 1, it could be 2, it could be 500 experts in that particular area who have come to some sort of agreement that in the absence of clinical trials, based on the knowledge that we have, we think that X, Y, Z should happen for this particular disease state. And then that goes into the clinical practice guidelines. I'm going to come back to that too in a moment. Best medical practices are determined both through empirical study, where effects can be observed, measured, and tested, and through expertise from experienced practitioners with the goal of increasing the effectiveness and efficiency of treatment. Ideally, evidence-based practice integrates all forms of evidence and knowledge, I would argue. However, a limitation of evidence-based practice in medicine is that research and practice are primarily conducted through a Western lens, which often does not consider context, traditions, or Indigenous ways of knowing. To give you a very clear example, Indigenous methodologies just simply don't fit through Western methodologies. Or in another specific example, I often hear Western trained practitioners say, that's so cool that Indigenous population X uses drug Z or traditional medicine Z. Let's study traditional medicine Z to see like how well it works, etc. But traditional medicine Z is not a Western knowledge system creation. I argue that we don't and we should not use one knowledge system to validate or invalidate another. In the same way that I'm not using my Western pharmacy lens to tell someone what Reiki practices work and don't work. That's not my wheelhouse, and that is not my ballpark. Leave that up to them. Leave that up to the experts in that area, right? So Indigenous medicines, I argue, should not even be studied in a Western context by Western-based researchers, published in Western peer-reviewed literature, and then taught in Western-based professions. They can simply exist as they are and be brought into the classroom as it is. We don't need to use our Western knowledge system to say if that's right or wrong. Evidence-based practice in medicine tends to privilege empirical research derived from Western methodologies that was developed through expertise and experience. This, though, might inhibit Indigenous practitioners from using traditional Indigenous knowledges to provide best care for their clients. So in me being a Soto and Ukrainian person going through multiple pharmacy degrees, I was not given this ability, right? And in fact, in very indirect and sometimes direct ways, that ability was like, absolutely not. Do not do that. There is no evidence based on what we describe evidence to be in a Western context. The assumption that empirical research is more valid than other types of research disregards the value of Indigenous health and medical knowledge that's been accumulated by trial and error over many centuries, and in some cases, millennia. We clearly survived, right? And these knowledge systems still exist. These practices, these medicines still exist. And in the hundreds of prescription medications that exist today, I remember learning in 2006 that there were just about 200 prescription medications on the market that were first used, discovered, created by Indigenous peoples. I've never heard stats like that again, and I haven't heard some of the current Western prescription medication being credited toward Indigenous peoples. Here's some more questions. How does research start? How much money is needed for research? Thinking about where power and privilege comes into all of this. Where does the money for research come from? Who reviews research grant applications? What methodologies for research are considered valid? And even among that, for peer-reviewed research, I argue in some contexts that I don't have any. So when I write a Indigenous pharmacy related piece and submit it to a peer-reviewed journal, I don't know of any other Indigenous pharmacy academics who would be reviewing it. So some commentary I've got back was really quite incredible, and actually quite a few rejections as well, because what I have to say doesn't fit in with the masses. So what isn't the answer in all of this? I've kind of alluded to this already. The answer is not to westernize Indigenous knowledges, medicines, and practices. They've already been researched, just not using Western methodologies. Requesting Western information, Western studies about Indigenous knowledges, medicines, and practices maintains the status quo and upholds Western medicine and practices as being superior. Coming back to those grades, how do we even rank the evidence? Well, all of these grades of evidence are in clinical practice guidelines. But what I argue is We have an expert consensus opinion from elders, knowledge keepers, medicine people, citizens of the various indigenous nations for millennia, in the thousands, in the millions perhaps of people. But will we ever get the chance to be given a grade D score in a clinical practice guideline for something? For example, I know how healing a sweat lodge can be. Clayton Shirt, who opened us up today, I've been in his own lodge, and that's incredibly powerful and healing for so many things. So how come sweat lodges aren't in the clinical practice guideline for all of those disease states, for all of those conditions, right? Because Indigenous thought processes and Indigenous thinkers are, for some reason, not perceived to be credible to be given a score of grade D. So even when a grade D evidence recommendation is put in clinical practice guidelines, let's say 3 pediatric oncologists decided that children with various cancer should have their vitamin D level tested every week. I'm coming up with a bizarre example just to emphasize my point. If they all said that, it goes in the practice guidelines with a grade D score, and then all funders, public and private, governments, provincial, federal, private plans, will now pay for those doctor visits, the screening, the blood test required for the vitamin D weekly, and that's an expensive test, but it now goes on the public radar of what's considered best practice or a standard of care. But without us giving or getting a grade D evidence score at minimum, no public dollars will be assigned to us in the same way that almost every plan out there does not cover attendance at a sweat lodge, the travel required to go to a sweat lodge, the offerings that you might be expected to provide or ideally expected to provide at such an event or ceremony, certain traditional medicines. That's up to each person on their own. Whereas the mass, the dominant population, gets sometimes free access to their ways of being, knowing, thinking, and doing, to their practices, to their medicines, but not Indigenous folks, the first peoples of this land. In order to work toward reconciliation in the healthcare system, Indigenous knowledges and evidence must be recognized as legitimate and integral to the health and well-being of Indigenous peoples. Although colonial policies and practices have absolutely worked hard to suppress our knowledges, our teachings, much like Indigenous peoples, though, our knowledges and teachings are resilient because they're still around. Findings suggest that the integration and blending of Indigenous and Western knowledges in the healthcare system can be facilitated by, and look at me, hypocrite right here, I'm citing peer-reviewed literature to tell you how to bring these knowledge systems together. Leaders and decision makers prioritizing this integration. We need that. We need the research community to accept traditional evidence as valuable and valid. We need to integrate Indigenous knowledges and approaches to healthcare into all health professions, education, and curriculum, both pre and post licensure. Without bringing Indigenous and Western knowledge systems together, Indigenous peoples access our own medicines and practices. That access remains nearly impossible. So how can these come together? Here's a few kind of basic, hopefully easy to achieve strategies to begin this process. So I would suggest to name the knowledge system from which you are working with whenever and wherever appropriate, and to phrase any criticism or questioning about another knowledge system or practice or approach in a way that will not feel patronizing. And I see this happen a lot in my own discipline with students and practitioners. Someone will say, oh, actually, I use rat root for my diabetes. And instantly I hear, oh, there's no evidence for that. And I'm thinking, how do you know that? Like, how did you know it that fast? I wish I could do a literature review or a search in a matter of milliseconds. But for some reason, folks are okay with immediately saying there's no evidence for that. But if someone asked about a prescription product, they'd say, I'll get back to you, and they would do some research. One phrasing that I suggest could be something like, you know what, that's really interesting. My training in Western pharmacy did not include information about rat root, but based on what I do know, it doesn't sound like rat root will be harmful. Or maybe I am concerned and I might say, I'm worried this might be harmful, but I do acknowledge that my own education in Western pharmacy didn't include any information or teachings about Indigenous knowledge systems or practices, such as rat root. So I'm just coming from a place where I simply don't know. I don't know if this might cause a drug interaction with your prescription medications or not. Um, you have your own agency as a patient, but my professional opinion from my Western knowledge system is that I don't know. If you feel so uninformed about it that you're very concerned that harm could happen, that is absolutely up to you with your professional license and designation to say, you know what, based on what I know and what I don't know, I don't feel comfortable suggesting that or allowing that to continue. But of course, the decision at the end of the day is up to the patient. Some considerations: asking someone to share information about a particular Indigenous medicine or looking it up in your Western-based resources immediately privileges Western knowledge systems. Such information as well, if it is available, will likely be criticized and presented through a Western lens. So I still do this, though. If someone presented rat root to me and they were on some high alert prescription medications like warfarin, an anticoagulant that has a really narrow therapeutic window, I would go look up in my natural medicines resource and see if anything is out there. Like, is there a drug interaction with warfarin? I want to know that with my Western pharmacy hat. I don't want to put my patient at harm. But even while I do that, I'm reminding myself, you know what, Jaris, you are privileging Western practices here, but that's what you practice. So that's what you should do. But just wanting people to realize that that is a privileging. As we move forward together, I encourage folks to engage in learning about anti-racism, anti-oppression. What might decolonizing practices look like in health professions? Has attention been paid to First Nations, Métis, and Inuit knowledges, etc., or is it just Indigenous, which doesn't exist, right? What do providers know about trauma-informed care, and how can you learn about that? What do providers know about moon time, so the menstrual period? There's a lot of teachings there that have a really direct and important impact on both traditional and Western medicines and ceremony. When and where do health professional students and practitioners have the opportunity to engage in simulation and experiential learning, like in a safe environment where they don't just get thrown out to the wolves and see if they're magically effective in intercultural counseling? We need to give folks a protected space and place to practice this type of work. I'm leaving you with just a couple resources. My Linktree website is at the bottom here, and you can find more than what I'm sharing on the screen. But if you want to know a little bit more in an introductory level about what Indigenous methodologies might be, it is not specific in any way to pharmacy practice research, but I just so happen to use that frame of thought for this publication. And then there's also this 3-part series that I've published in the Canadian Pharmacist Journal. It's totally open access and free, and it looks at tensions between Western and Indigenous worldviews in pharmacy practice and education, but I would argue in any Western-based health profession, practice, and education. That's everything I have for all of you. I so appreciate you taking the time to include this as part of your day, as part of your personal and or professional journey. I love connecting with folks anytime, whether that's through email or through any of the social media handles I've shared. And just thank you once again to Clay Shirt and to the Ontario NEIHR for making this information available to everybody. And I know that we're right at the hour and some folks might need to hop off, which is totally fine, but I'm also happy to entertain some questions. I have some of these already listed in the Q&A box, so I'll just read out some of these. Some folks asked about the recording. Yes, this will be posted to the Ontario NEIHR website afterwards, so you'll be able to access this recording. Someone asked, regarding the dominant knowledge in a field, what's the connection or not between efficacy and legitimacy? What's the possibility that dominant knowledge is that way because it works better? I would argue that that's just because the dominant knowledge system was studied in the dominant knowledge system's methodologies, right? How do we know that it works better? Some of these interventions haven't been studied versus an Indigenous practice or medicine, and nor should they be, in my argument, because those medicines and practices don't exist within a Western paradigm. They should be studied within an Indigenous paradigm. So it's possible that we can just have multiple seats at the table. In fact, sometimes I use this table analogy in that I think in this Western system, we kind of view healthcare as the table, and then other folks are sitting around it. But I perceive healthcare to be a table with Western knowledges, systems, practices being one chair at the table, Indigenous being another chair. I'm using a pan-Indigenous approach here. Traditional Chinese medicine being another chair. And these can all exist and they can all be true and they can all be part of somebody's own health and wellness journey. It does not have to be one, nor do any one of those chairs need to be the person or authority figure to validate or invalidate any of the other chairs around the table. Looking at another, someone said, sorry, you're neglecting a huge history in the philosophy of science that, for example, distinguishes positivism from empiricism from realism. Certainly those aren't typical topics in health studies, health sciences studies, but distinguish between epistemology and pedagogy. Great question, and I'll just maybe summarize this in a different way. There are very many scholars and thinkers out there who talk about the different forms of knowledge out there. There's an author, Indigenous thinker called Castellano, Castellano, and there's a work from the year 2000 where this author, Brant Castellano, talks about three ways in which we acquire knowledge. One is through empirical study or research, observation, etc. One is traditional knowledge that's been passed down to us over time. And the third is through revelation, revealed knowledge. So, how many times have you had a sleeping dream or a waking dream, or you're watching a movie or listening to someone talk, and although they're not specifically saying something, something's been revealed to you. Oh, I better do this, or that better happen, or oh, it all makes sense now, right? Even if someone didn't spell it out for you,
I'll
that's
get back to
been
you. I'm in a
revealed.
webinar. I
Oh,
have to do the closing.
sorry, Clay, you're just unmuted. No problem.
Sorry, brother.
No problem. Yeah, those were the few that I saw, besides some extra thank yous. Folks still might have a moment just to share any other questions or thoughts or reflections, but I'm also happy to receive those in a personal email or social media message or something otherwise moving forward. But with that, I'll just hand it back to Clay to close us off. And now your mute is on, Clay.
Well, I mean, it was off, and again, my apologies, brother. But what a wonderful talk! Such a amazing talk. It's such a food for thought. There's so much to think about, and it got me thinking. And I just appreciate all the good words, everything you said, and it's just amazing. Again, I just we invite spirit in, so we have to put it this way: we have to send them on their way wherever they need to go, right? And that is up for question. Where do they go, right? And that's the beauty of that, right? And questioning all that and seeking those truths, many truths that you talked about, all of this different approaches and everything. And we're also, just a reminder, and I'm reminded myself that this is my own view, but and a lot of us have this view. They're still trying to colonize us. That process is still going on. Terminologies have changed, technologies has changed, but the process is still there. And what you're talking about and and it's just so wonderful what you were saying is just we're learning again to how to deprogram ourselves, right? And how to look at these things and say who we are. And as Indigenous people, we're saying to ourselves again, learning again that there's nothing wrong with us, right? All of this. And our medicines, our view has value, and it has a value that we want to share with the world to help the world. And that's the thing that we're always about, Indigenous ways of knowing and being, is that we're always going to share. It's part of our teachings. It's part of our way of life. It's in our DNA. It's in our blood. We're always in, despite what we go through, and what you talked about, the resilience, right? All of that. And that's what inspires me to keep going, right? We're always going to do that, and we always will, and we'll teach our children's children this, right? All of this. So again, thank you for that, for all your words. It's such a, made me think about so many things. So with that, I just want to say miigwech. I want to say thank you. And I ask for the blessings for you, for all of this, because of the work you're in there. And you're just that one person, you know, breaking that ground for the next generation. So again, to give you strength to get through this, I say thank you to the earth, the sun, the sky, and creator, and the blessings for everyone who came here today. And I thank you, creator, for this beautiful day. And I thank you, creator. We thank you for the gift of life. All my relations. Miigwech. Thank you, brother.
Miigwech, Dr. Swidrovich. It was a wonderful presentation. Thank you once again.
Bamapi.